Thank you very much for having me. I really appreciate the opportunity. And I think that that it's important in a community of this size for business leaders and the general public to understand what we're capable of here in Alton, Illinois, compared to what they advertise at Orange Jewish, SLU, because they tend to advertise cutting-edge technology, and it's important for local business people to understand and their family members to understand that we offer exactly that same cutting-edge technology. The Stryker team here, Caitlin, Drew, and Mike, put together a wonderful package on joint replacement, and we do exactly the same things locally that they do in downtown St. Louis when it comes to this type of orthopedic surgery. And in fact, every time I see statistics, Alton Memorial is at the top of the BJC system in terms of fewest complications, infections, blood clots, etc. So we really have in both Alton Memorial and St. Anthony's top flight orthopedic joint replacement programs. If you have arthritis, you're not alone. Okay, 43 million people in this country suffer from arthritis, and that will increase dramatically as the baby boomers move through this next decade, up to 60 million by 2020. What I'm going to touch on are the causes of joint pain, treatment options, the new custom fit knee replacement, and the newest, the mobile bearing hip, which is what we're doing here locally. We'll also touch on shoulder replacements and realistic expectations. Most common types of arthritis are osteoarthritis, rheumatoid, post-traumatic arthritis after injury, and avascular necrosis, which means loss of blood supply to the head of the femur in the hip, or to the head of the humerus in the shoulder, where the bone then breaks down because of a loss of blood supply. Here's a normal knee X-ray on the left. You can see that there's good joint space, no bone on bone. And over here, the cartilage space is completely gone. The calcium is being laid down, and that's a very painful condition. Bone on bone, when the cartilage wears completely away, is the most common reason to do a joint replacement. Here's the hip. Again, normal joint space on the left, and loss of joint space here, cyst formation in the head of that femur, and again, a very painful condition. Initial treatment options obviously include medications. We put people on anti-inflammatories, sometimes non-steroids, sometimes steroids. Physical therapy can help with maintaining joint motion. Outpatient arthroscopy through little incisions to clean out the joint is another thing to try. We have things, as you probably have heard, that are joint fluid supplements like Synvisc, which is an injection. It's really like adding a can of oil to your car. If the oil level is a little low, it just lubricates it well. Then there's talk about partial knee replacement, and whoever wins the partial knee replacement, let me know. And then total joint replacement, of course, is the end of the treatment options. So, who is a good candidate for knee replacement? The pain in the knee or the hip or the shoulder has to be severe enough to interfere with daily activities, interfere with work if it's someone who is not yet retired. And of course, the joint replacement goals are to relieve pain and to restore motion. And we do encourage patients to do things like ride bicycles, walk for fitness after joint replacement. More than 300,000 knee replacements are performed in this country every year, and a similar number of hip replacements. Many of those, though, are not elective. They're following someone breaking their hip and having to have the femoral head replaced. So here's a little anatomy of pelvic bone, the diseased cartilage in the joint, and of course this is the femur. Caitlin, why is this picture in here? This is the hip, I guess.
Yeah.
And now we're going to go over some more anatomy. As you can see, when the erosions occur in the head of the femur, it becomes very irregular and has to be cut off during a hip replacement. A new socket is put in, and that's generally just press fit. A stem goes into the upper femur, the head goes on there, and then the whole thing is put back in joint. The total hip is held in place just by the soft tissues and the tension in the muscles so that it's a stable construct, occasionally dislocate, not very commonly. There again, normal, abnormal, and now with the knee replaced, just a schematic. or the hip replacement, I'm sorry. And that's what the x-ray looks like after a hip replacement. You can see how we reamed to the exact size of the canal within the upper femur. This is reamed out to just a little bit smaller than need be, and then that socket is punched in there, and bone is compressible so it holds it snugly, and bone grows into the back of the stem and the socket in order to hold it in place. The new ADM is the hip that we're using now, and it has a contoured socket in the upper left there to accommodate some of the tendons around the hip joint and facilitate excellent range of motion. We're going to see here that the older standard hip allowed overall range of motion through approximately 90 degrees. And with the new mobile hip, where the inner plastic portion is able to move, there's a dramatic improvement in the amount of mobility in the hip. And that improves walking. If you think back a couple of years, Tom Watson almost won the British Open on his total hip replacement. And so full range of motion is possible. 138 degrees with the older style. With the newer style, that improves by about 8 to 10 degrees because of the extra mobile portion inside, that polyethylene piece, which is very, very stable. It allows patients to rise from a seated position, which in the old days, in the 70s, 80s, and 90s, we didn't allow people to sit on lower stools because of the fear of dislocating the hip. But with the new technology, they can sit on lower surfaces and not have to fear dislocation. In the old ones, there was impingement on the lip of the socket, which could allow the thing to lever out. Now that impingement is gone with the new ADM hip that we're doing in these last few years. You can see the contours in this hip and the amazing range of movement that can be developed following rehab. I think we're going to move on to the knee now, aren't we? After hip replacement, yeah, here we go. After hip replacement, you've got a great range of motion these days, stable fit, less wear, and most of these hips are going to stay in patients forever. Normal knee anatomy, the kneecap and the patella, healthy cartilage down here. In arthritis, again, the cartilage is worn away, exposing the subchondral bone. It's actually more pink than red, but that gives you the idea of what it's like when the cartilage completely is worn away. So we cut off the end of the femur and the upper end of the tibia, and what we're trying to do is restore normal anatomy. We're taking off the same amount of bone as we're putting in terms of the metal and the plastic. There's just a picture of your knee. You can see how well it moves and how that kneecap runs in the groove. And you can imagine how painful the knee that's this eroded is. We do use very accurate jigs to cut the end of the femur and put a new steel piece on there, and then the upper tibia with a polyethylene component again, and you can see how that moves for the patient. We also replace the back of the kneecap, which is not depicted right in this slide. So normal, diseased, and then after the replacement with all components in position and very stable. Here's what the x-ray looks like. You can see how we make accurate cuts all around to restore normal anatomy and shape. And there is a plastic button on the back of this kneecap, which has been cut off and plain smooth. The upper tibia also replaced in this case. And the importance of pre-surgical planning. And these guys come in and look at the patient's x-rays before we take them to the OR. They templated for size and for angle, and we want to, again, restore normal anatomy because most of these knees are deformed. Here's an MRI scan, which we use moving forward here to create custom-made cutting blocks so that we get the end of the femur and the upper tibia cut as accurately as humanly possible. And the proprietary software, which I could tell you about, but then I'd have to shut it down and you couldn't tell anybody. So I won't tell you about that, but it's very accurate, it's very good, And we're getting tremendous results with this shape match technique. Restores, again, normal anatomy and the normal motion in your joint. These are the example of the cutting jigs, and they, once we open the knee at surgery, are pinned in place, and just as I said, it's really hard to imagine that they can be as accurate as they are, but they do a great job. So there again, disease, the MRI, and then the knee replacement. Here with the back of the kneecap included on this slide. These are lasting forever, and the ultra-high molecular weight polyethylene, the plastic liner, is really the key to the longevity. This almost always holds beautifully. This always holds beautifully, but it used to be that the plastic would wear out 10, 15 years ago, and that is no longer a problem. The amount of wear in the new Triathlon X3 is down 96% compared to the old polyethylene that we used 5 to 10 years ago. So that's going to really extend the life of that new knee. In the shoulder, briefly, again, normal anatomy, you can see a good cartilage base here. The shoulder is a little different an animal because it's a very shallow socket. It's not like the hip joint where there's a really deep socket that's roughly the size of the outside of a golf ball. This is more like a saucer, and so it depends upon the soft tissue labrum around the outside here to deepen the socket and maintain stability. That makes total shoulders technically a little bit more difficult than hips or knees. The joint capsule is extremely important in maintaining the stability of the shoulder joint post-operatively. The rotator cuff was depicted there, and that's also very important. So here again, normal shoulder with good space, right there. And here, bone on bone, no space at all. So that's going to be a painful joint. This is just the normal anatomy. And again, what we do in the shoulder is replace the socket, in most cases, not all, and then always a new steel head, and we'll show a video of that one coming up here, I think. There we go. So we dislocate the upper humerus, cut off the head, put in the stem, put in the socket, which is cemented in most cases, and then we put on a head that is matched to the patient's size so that they begin to be oriented exactly to the proper shape and provide pain-free function. The idea again is to replicate natural anatomy, to relieve pain and restore function. And of course the therapists have a lot to do with post-operative care and regaining strength and range of motion. Here's the X-ray of a replaced shoulder. I think this one is probably without a socket, but just the humeral head. And I think only about half of the surgeons doing shoulder replacements do both components all the time, because patients don't seem to have a lot of trouble with range of motion, even though they only have the head replaced, as opposed to the socket as well. And there's therapy. In hospital for all three of these procedures for 2 to 5 days. The average would probably be 3. I send my patients all home on day 3 or to rehab. The overall initial recovery is 6 to 12 weeks, and then of course maximum recovery does take up to 1 year in all 3 cases of hips, knees, and shoulders. And the rehab therapists are very important to us. Patients start their therapy the morning after surgery under supervision, and both the physical therapy staff and the nursing staff take care of getting that patient to regain their muscle strength and to increase their range of motion. Physical activities are almost unlimited after joint replacement. Once complete recovery is available, the only thing we don't want people doing is running or jumping, particularly because that can jar the components loose. But in terms of range of motion, patients can do whatever they'd like to for purposes of playing golf, walking for fitness, riding a bicycle, and get back to fully normal activities. That's really all I have.